So you can share the screen.
Okay, yeah, wait 1 minute.
Yeah, sure.
Okay, it's visible, right?
Not yet. Yeah, now it's visible.
Okay, yeah.
Yeah. Okay, so I'll just check if we are live on YouTube or not. Yeah, we are live on YouTube.
Okay.
Cool. Yes. Yeah, I think we should start. Yes, we'll start in 2 minutes, guys. Just 2 minutes. Wait. Okay. Okay, guys. So good evening, everyone. And today we have with us Dr. Kiran Shetty. He is PhD in cardiology, and he is now working as a senior manager in research and development department at cardiac devices division at Meril Lifesciences Private Limited, Vapi, Gujarat. Meril is known for all the cardiac devices like ASD closure, VSD closure, and in the new technology also they are entered now. So they are preparing, they are manufacturing the leading tower in India, transaortic valve catheters, okay, and transaortic valve replacement devices. Right. So Dr. Kiran Shetty, my friend, is senior manager in R&D department. Right. So today, before starting the class, I just want to, a little announcement I want to do, guys, about our courses, upcoming courses and conferences. So I'll just, discontinue this screen sharing, and I will, yeah, share this, right. So as you can see here, we are starting our new batch for international pharmacy licensing exams in January. Okay. So for that, admissions are going on right now, and you guys can come up and join us for the international licensing exams programs, training program for if you're interested for Canada, PEBC, if you're interested in CAPS for Australia and New Zealand, if you're interested in MOH, DHA or HARD for UAE, or for USA, FPG and NEPLEX. you can come to us, you can join us, and you will get the good discount, and in the your fees will be very, very less here. And you can join us, you can contact us on these phone numbers and email IDs if you're interested. Okay, and you can book your slot by paying 2,000 rupees only. And now our one offer is going to end very soon on 10th December at 15% direct off offer. Okay, so our specialties for the licensing exams are that our two batches are already going on. So few of the candidates from these course batches are writing exam in January. Okay, so we have our international and national expert faculties on board who will take your 75 classes and interactive sessions live on Zoom. And we have classes flexible timings on the Saturday, Sunday, and Fridays, weekends. And you'll be getting all the materials and mock tests for at least 1 year, and complimentary career guidance will be given to you. Okay, so this is the first announcement. And one more little announcement I have, guys, for you, because we are coming up with the conference, with one of the best conference in India, one of the first type of conference in India. So that is international symposium on medication therapy management. And this is for first time in India. You guys know that this is for first time in India. Okay, so you guys can take part in that, and you guys can attend that. Okay, I'll just to share one more screen for a second, just for a second. And now, very exciting offer here is that you can participate in a survey related to the conference. And you can win exciting prizes, and you can win free registration. So if you register to this, if you do this survey with this link, the top five or five lucky winners will get free registration to the conference. And it is just just to check your knowledge on medication therapy management. Okay, so this is medication therapy management knowledge club survey. You can just take part in this. Okay, guys. So thank you very much for listening. Now I will invite Dr. Kiran Shetty to share his screen and start the lecture on beta blockers. Very welcome, Dr. Kiran Shetty.
Hello. Good evening, everyone.
Good evening.
Uh, I hope I'm audible properly.
Yes, very much audible.
Okay. Shall I directly begin the class then?
Yes, why not?
Okay, then. Yes. Thank you.
Thank you.
Yes. Okay. So in today's class, we'll be covering mainly the beta blockers. What are beta blockers? On which receptor they act? Or how they act? And what are the pharmacological actions of these beta blockers on various organ systems? And what are their possible therapeutic uses? What are their side effects? What you when you're using the drug on a patient? And few drug interaction that we will see in today's class. Okay, so these beta blockers are originally dichloroisoprenaline derivatives. So this dichloroisoprenaline was the first beta blocker which was invented during 1958. But unfortunately, it didn't have any clinical use. So that is mainly because of its partial agonistic action. And also in the preclinical study, it's shown a teratogenic effect. So that is why it did not come to therapeutic use. So next, in 1962, Black and Stephenson, they found out or they invented propranolol, which is one of the first beta blocker. So in 1963, propranolol became a first clinically used beta blocker. Later, in 1988, Sir James White Black, he awarded Nobel Prize for the invention of propranolol. So these beta blockers, you know how they act. So for every drug to act, they need to act on certain receptors or enzymes or ligands or some metabolic pathways. Here, beta blockers, as their name says, they act on mainly beta receptors. If you remember from the adrenergic agonists, so there are mainly three receptors, beta receptors. They're mainly beta 1, beta 2, and beta 3. Beta 1 receptors are mainly found in kidney, heart, and adipose tissue. So whenever an agonist binds to beta 1 receptor, agonist in the sense of epinephrine or norepinephrine, when that agonist binds to the beta 1 receptor, especially in the kidney, what happens is it causes the release of renin, whereas in the heart, they causes increase in the heart rate, force of contraction, they increase the cardiac automaticity and also cardiac output. Whereas in the adipose tissue, they produce lipolysis. The beta 2 receptors, they are mainly or predominantly, you can say, they're found in the smooth muscles of your blood vessels or bronchi or bladder, uterus, GA smooth muscles. So in general, what beta 2 receptor, whenever there is activation of beta 2 receptor by the agonist, what happens is they causes smooth muscle relaxation. In case of blood vessels, you can say they cause vasodilatation. And in the liver, they cause glycogenolysis. Other than that, the activation of beta 2 receptor, what they do is they reduce the release of histamine, and also in adrenergic neurons or nerve terminals, they increases noradrenaline release. Whereas beta 3, it is observed mainly found in adipose tissues. So the activation of beta 3 here in adipose tissue causes lipolysis. Now, the beta blockers, the name, as their name says, what they do is they block beta receptor. Either it may be a beta 1, beta 2, or beta 3, and thereby they prevent or the block the actions which are produced by the agonist. For example, say epinephrine or norepinephrine. Now, when you say beta blocker, you just cannot keep on saying beta blockers. You have to classify them. So how you can classify usually these beta blockers? So the classification of beta blockers can be done mainly based on their selectivity towards their receptor. That is mainly beta 1 or beta 2 or beta 3. Apart from that, you need to consider their intrinsic activity in beta receptors and their affinity towards alpha receptor, whether they have any affinity, or whether they are lipid soluble or not lipid soluble, whether they cause any membrane stabilizing activity, or whether they produces any vasodilatory effect on the blood vessels or any smooth muscles. Then even you have to consider their pharmacokinetic parameters. The classical classification of these beta blockers, they are mainly based on their selectivity, that is, whether they are selective or non-selective. So you can also say them as a different generation, that is the first, second, or third generation. Usually the first generation beta blockers, they include a non-selective beta blockers. So that includes the first in the class, that is propranolol. Other than that, you have nadolol, pembutalol, pindolol, timolol. Second generation, they are not non-selective. They are selective for beta 1 receptors. So this second generation, or you can say the beta 1 selective beta blockers, they include mainly acebutolol, atenolol, bisoprolol, esmolol, and metoprolol. Whereas there is a third generation beta blockers. So these third generation beta blockers, they have some additional properties. Along with the beta receptor, they also block, or they also have affinity towards alpha receptor. So those drugs includes mainly labetalol, carvedilol, cartilol, bisimidolol. Okay. So there is a one more action that is mainly vasodilatory property. So there are few drugs, that is a celiprolol or betaxolol or nebivolol. These three drugs, along with the blocking of beta receptor, they also produce vasodilatation. So there are certain drugs among these beta blockers, they have some intrinsic sympathetic activity. Intrinsic sympathetic activity in the sense, along with blocking this beta receptor, they also have a tendency to activate the beta receptor, especially the beta 1 receptor. So those drugs include mainly celiprolol, oxaprenolol, pindolol, allopurinol, or acebutolol. So, but this intrinsic activity is having some, controversies. Okay, so they claim that they have some, because of this intrinsic sympathetic activity, there is some benefits, but it's a controversial. So they say that because of this intrinsic sympathetic activity, they can prevent the profound bradycardia, which is produced by these beta blockers. Or it can also be used, or you can say they are preferred in those patients, those who are having a tendency to develop bradycardia. And also, the withdrawal symptoms after the chronic use of beta blockers is very less likely in case of these beta blockers, that is beta blockers to the intrinsic sympathetic activity. And these drugs, they do not, alter or change any lipid profile in the patients, or they do not, they do not cause any effectiveness, or does not produce any effectiveness towards the migraine prophylaxis. Okay, so these are the few things which you need to know about the beta blockers, which have intrinsic sympathetic activity. Among these beta blockers, the lipid solubility varies between the drugs. Okay, so here among beta blockers, nadolol is having longest acting. So that means it is not highly lipid soluble. It is very less lipid soluble. Okay, and if the drug is highly lipid soluble, that means the drug can cross blood-brain barrier very easily and can produce its effect. So that means maybe here the propranolol, metoprolol, or labetalol, these are the drugs, they are highly lipid soluble and can readily cross the blood-brain barrier. So there is a disadvantage with the drugs which are having high lipid solubility, especially the beta blockers, because they tend to cause forgetfulness, or there's an increased daydreaming or nightmares, and it can also cause depression. So on long-term states, users, sometimes what they do is they can cause alteration in the mood. So, but this property of propranolol can be used in case of anxiety issues. Okay, so propranolol is the one which is mainly used in patients or the people who have a stage fear. I mean, those who having a fear to talk publicly. So in those persons, propranolol can be used mainly to prevent those anxiety symptoms. As I mentioned earlier, beta blockers also have membrane stabilizing activity. So membrane stabilizing activity in the sense they produce action which is very similar to that of local anesthetic. That means they tend to block sodium channel. Okay, so among the beta blockers, propranolol is having maximum membrane stabilizing property. So apart from propranolol, you have metoprolol, labetalol, acetaminophen, or pindolol, which possess membrane stabilizing activity. So, but as such, to produce this membrane stabilizing activity, you need to give these drugs in a pretty much larger dose than the normal therapeutic doses. So this is not clinically significant. Another important property of beta blockers is their capacity to induce vasodilatation. These drugs can induce vasodilatation, or they can produce vasodilatation by various means. So they can cause nitric oxide production, or they can produce beta-2 receptor agonism, that is mainly by the intrinsic activity, or they can also block alpha-1 receptor, because alpha-1 receptor can cause vasoconstriction, right? So by antagonizing alpha-1 receptor, they can produce vasodilatation, or by blocking the entry of calcium, or by opening potassium channels, or even also by preventing or by producing antioxidant activity, that is mainly by inhibiting the activity or the effects which are produced by reactive oxygen species. So you can see that one by one. Well, here, usually what happens is this reactive oxygen species, what it does is it causes LDL oxidation. So they also cause lipid peroxidation, or because of all these things, this reactive oxygen species, it causes endothelial dysfunction. So later in stages, it can cause apoptosis. So these drugs, beta blockers, because of their antioxidant property, they prevent the actions which are produced by this reactive oxygen species. They can also cause the induction of nitric oxide. So whenever there is an induction of nitric oxide, what happens is it produces something called cyclic GMP. Cyclic GMP tend to cause vasodilatation. So whenever which is taken by the heart of the patient can be reduced, so thereby it tend to reduce the cardiac work. Another one is alpha blocking property, especially the drugs like, for example, say labetalol and carvedilol. Along with the blocking beta-1 receptor, they also block alpha-1 receptor. So what is the main function mediated by alpha-1 receptor? So that is mainly to produce vasoconstriction, right? So now, because of the blockade of the alpha-1 receptor, what happens? There is no vasoconstriction, and also it tend to reduce the second messengers, for example, say IP3 and diacylglycerol. So these second messengers are very essential for producing uh, vasoconstriction or to produce the action which is mediated by alpha 1 receptor. So now their level is very less. So that will lead to vasodilatation. So the end result is decrease in cardiac load or the decrease in the cardiac work. Now, we can say what are the different actions, or you can say the pharmacological actions, which are produced by these beta blockers on individual organ system. First, we'll consider the cardiovascular system itself. As the name says, beta blockers, they block the beta receptor. I hope you remember what happens when a beta 1 receptor, which is present in your heart, when it gets stimulated. If you remember, whenever there's a stimulation of beta 1 receptor, what happens? There is an increase in the heart rate, there is an increase in the force of contraction, automaticity. So in turn, that will increase your cardiac output, cardiac work. As your cardiac output and cardiac work increases, the oxygen consumed by your cardiac tissue also will be increased. So that will put more pressure on your heart. So when you give these beta blockers, they block the beta receptor, right? So when they block the beta receptor, so the heart rate, force of contraction, or the work which is exerted on the heart or the cardiac tissue will be reduced. So that in turn will increase the cardiac efficiency or increase the efficiency of your heart. So in blood vessels, usually they tend to increase the peripheral vascular resistance, they tend to reduce the peripheral vascular resistance, and thereby they reduce the total peripheral resistance. So thereby the blood flow, the force which is required for the flow of the blood also can be reduced. So in general, they reduces noradrenaline release. That is mainly because they block beta 2 receptor, especially the adrenergic nerve terminals. And if you remember, they also reduce renin release from the kidney, and they produce or they cause nitric oxide production, so which will lead to vasodilatation. And also because of the beta 2 activity, there'll be a vasodilatation little bit. And by blocking alpha 1 receptor, they prevent vasoconstriction, and they also block calcium entry and potassium channel opening. Because of all these several actions, or you can say them, because of these several mechanisms, they tend to increase the cardiac efficiency in those patients. In respiratory tract, actually, respiratory tract it contains smooth muscle, right? Usually, smooth muscle contain your both beta 1 and beta 2, but predominantly beta 2 receptor. So, if your patient is a hypertensive patient, comes to your clinic for a consultation, and you need to prescribe a beta blocker for that person, just imagine. So, in that scenario, if you forget the patient is having like a COPD or bronchial asthma, and if you prescribe non-selective beta blocker, then what happens? Along with the producing the beneficial effect which is required for the patient, along with that, by blocking beta 2 receptor, they tend to cause bronchospasm.
Dr. Kiran,
yeah,
can you please go little bit slow? Students are asking for a slow from YouTube. Little bit
okay,
slow.
okay,
Yes.
okay, yeah, sure,
Thank you. Thank
because
you.
I don't get any comments here, that's why. So
Oh
I
yeah,
know.
that's why I'm just getting all the comments I'm reading. So people are asking for to go little slow. Okay, thank you.
Oh, okay, yeah, thank you. Okay, I'll go slow. So your respiratory tract smooth muscles, it contains mainly beta 2 receptor, right? So when you prescribe a non-selective beta blockers, what happens? Along with the blocking beta 1 receptor, it also blocks beta 2 receptor, which is present in your smooth muscles. So in this case, a patient is having a hypertension and also consider say a bronchial asthma. In that patient, if you give a non-selective beta blocker, what happens? See, for hypertension, whatever the beneficial effect, that is mainly by reducing the force of heart rate, force of contraction, all those things, and by reducing cardiac output, it can manage the hypertension, right? Increase the blood pressure can be managed. But at the same time, they also act on the beta receptor, beta 2 receptor, right? Which is present in the bronchial smooth muscle. So now, because of the blockade of beta 2 receptor, which is present in the bronchial smooth muscle, it leads to bronchospasm, so which is not required for the patient. So you should not prescribe non-selective beta blockers to a cardiac patient who is also having bronchial asthma. So in that cases, you always have to go for selective beta 1 blockers. Okay. These beta blockers, they also have or they can also produce some metabolic effects. So the first important thing what they do is they produce something called dyslipidemia. So this, for example, say among beta blockers, when you say a beta blocker, there is something called a prototype drug, right? So among beta blockers, propranolol is considered as a prototype drug. So what they do is usually they tend to alter your plasma free acid level, or they can also cause changes in the plasma triglyceride level, LDL and HDL ratio. So this will be increased during this beta blocker therapy. Okay. And one more important thing which you need to remember is they tend to mark the sympathetic activity, a sympathetic manifestation. For example, say patient is diabetic and he's also taking beta blocker, for example, say propranolol, he's taking it. So when patient is a diabetic, okay, and he's on anti-diabetic medication, okay. So one of the common side effects of anti-diabetic medication is hypoglycemia. So how you will recognize patient, you are hypoglycemic or patient is hypoglycemic? That's mainly because when you're hypoglycemic, there'll be a shivering, there'll be a severe sweating, there'll be a palpitation, all those signs you can notice in a patient. So immediately whenever a patient realizes he is having hypoglycemia, he can eat sugar or candy or chocolate so that his blood sugar level can be increased. But if the patient is taking beta blockers, what they do is they block beta receptor, right? So usually the hypoglycemic symptoms are manifested or they are produced via beta receptor. Now, when the beta receptors are blocked, these hypoglycemic symptoms cannot be manifested. So that means patient will not notice their hypoglycemic symptoms. So that means the patient can go to hypoglycemic state. So that is why you should be very careful when you are prescribing these beta blockers in patients who are having or who are diabetic. Effect of beta blockers on eye and skeletal muscle. Again, if you recall from the adrenergic agonist chapter, especially the beta receptor agonist, if you remember, even the beta 2 receptor, which is also present in your eyes, especially in the ciliary muscle, right? So, but as such, if you're giving the oral medication of beta blockers, then it will not produce any effect on your eyes. Okay, only the topical application of beta blockers can produce some clinically observable effect. For example, say if you're giving a topical beta blockers, what they do is they reduces this aqueous humor secretion, and thereby they can also reduce intraocular tension. Okay, but they do not cause any changes in the pupil size, or they do not cause any changes in the accommodation. Okay, so that way they are kind of beneficial, especially in patients those who are having glaucoma, especially timolol compared to other beta blockers. So in skeletal muscles, these beta blockers, what they usually do is they inhibit adrenergically provoked tremor. For example, say if the patient who is on any adrenergic agonist, for example, one of the common example I can say is a patient those who are having bronchial asthma. So for bronchial asthma patients, you usually prescribe MDI, right? Meter dose inhaler that usually contains salbutamol, right? So if the patient is taking this salbutamol for a very long period, then if you observe that patient or those patients, they have a small tremors in their hands. You can observe. So that is mainly because of the long-term usage of adrenergic agonist. So these twitchings or tremors, which is induced by adrenergic drugs or agonists, can be blocked by using beta blockers, especially which are acting on beta 2 receptor. So here you can give propranolol, again, which is a non-selective beta blocker. So by blocking this beta 2 receptor, these drugs can inhibit adrenergically induced or provoked tremors. All the beta blockers, they vary in their pharmacokinetic features. For example, say here the prototype drug propranolol that undergoes extensive first-pass metabolism. So when a drug undergoes first-pass metabolism, that means its oral bioavailability is very low. Okay, so if you want to increase the bioavailability of the drug, then you need to go for systemic route, not the oral route. If patient is taking propranolol for a very long period, say more than 5 years, okay, then what propranolol will do is it tend to reduce hepatic blood flow. Whenever the hepatic blood flow is reduced, the metabolism of the drug also will be reduced. When metabolism of the drug is reduced, that means the bioavailability of the drug is increased. So among the beta blockers, nadolol is having one of the longest acting beta blocker that its effect can be seen up to 14 to 24 hours. And whereas ashnolol is one of the shortest acting beta blocker. It is having a rapid onset of action and ultra short acting. So it can be used mainly for emergency purposes. Okay. And it is also a class 2 antiarrhythmic agent, which can be used in supraventricular tachycardia. As such, most of the drug, whatever you take in a day-to-day life, they will be having interaction with one or the other drug, or maybe with other drugs, or with your food, what you consume. Okay, so here, beta blockers, they also have some drug interactions. For example, say if you're consuming or if you're prescribing beta blockers along with the calcium channel blockers, for example, say verapamil or even with the digitalis, what happens is they produce an additive depressant effect. That is especially the depression of the sinus node and AV conduction. They reduce the AV conduction. So now because of this, they can lead to cardiac arrest also. Okay. So, but other than this, propranolol is safer to be used along with the nifedipine. Nifedipine is again one of the calcium channel blockers. And at the same time, if you're using these beta blockers along with NSAIDs, then what happens is NSAIDs tend to attenuate the antihypertensive effect of beta blockers. So that time you have to be very careful whenever you are prescribed the drugs. And as I said previously, the insulin or the oral antidiabetic drugs, these beta blockers, they block the beta receptor, right? So the hypoglycemia, which is produced after the consumption or after the usage of insulin or oral antidiabetic drugs, can be masked. So there will be a delay in the recovery from the hypoglycemia because patient will not notice the onset of hypoglycemia. Another one is there is one more drug called lidocaine, or it's also called lignocaine, which is a local anesthetic. So its metabolism also can be reduced, mainly because propranolol or beta blocker in general, they tend to reduce hepatic blood flow, right? So because of that, the metabolism of lignocaine or lidocaine is reduced. So which will make the duration of action of lidocaine is much larger or longer. So in general, what are the uses of these beta blockers? So all the effects, most of the effects which are produced by beta blockers are, they are circling around cardiovascular system. Okay. So in general, they can be used for the treatment of essential hypertension or angina or arrhythmias, especially supraventricular arrhythmia, or it can be used for the prevention of a myocardial infarction, or during myocardial infarction, you can give us an early administration, or even after the onset of the MI. Then you can give it for the treatment of cardiac failure, CCF, or portal hypertension, or aortic dissection, especially Marfan syndrome, or subarachnoid hemorrhage, okay, or mitral valve prolapse. Okay, so these are the few scenarios where you can use beta blockers. As I mentioned during the classification, there are certain drugs, they have some specific properties. For example, here you can say the cardioselective beta blockers. Among beta blockers, nebivolol, betoxolol, bisoprolol, okay, acylbutalol. These are the drugs, they have a cardioselective property. Why? Mainly because what is the advantage or what is the use of being cardioselective? Because these are the drugs, they are more safer in asthmatic patient or in diabetic patient or patient who are having peripheral vascular disease. Okay, mainly because they do not act on other receptor other than the beta 1 receptor or the myocardium, or especially the beta 1 receptor which is present in the heart. So that is why they are much more safer, and they do not alter your lipid profile, and they do not alter your exercise capacity. Okay, so because of these reasons, they are more beneficial in patients those who are having comorbid conditions. So we'll go by one their therapeutic uses. So beta blockers, one of their common use is in the treatment of essential hypertension. So even though these beta blockers, they tend to have several other side effects, but the side effects, when you measure the benefits which is produced by these beta blockers over the side effects, the benefits will outweigh the side effects. So the side effects, for example, say sexual dysfunction or fatigue or depression, that can be overweighed by the beneficial effect produced by these beta blockers. And you can think of giving or prescribing beta blockers in case if patients are intolerant towards AC inhibitor, that is angiotensin converting enzyme inhibitors, angiotensin 2 receptor blocker, for example, say losartan, okay, that is angiotensin receptor blocker, AC inhibitor, for example, say captopril. So if these drugs are contraindicated, or in case, say, a patient who are having hypertension along with the tachycardia, or patient who have got myocardial infarction or angina or heart failure. In these case scenarios, you can think of prescribing beta blockers. Apart from that, you can also use beta blockers in hypertensive crisis. But in hypertensive crisis, one of the drug of choice is mainly sodium hydroxide. So, but along with that, you can also use esmolol and labetalol. Okay, esmolol can be given at dose of 0.25 to 0.5 mg per kg intravenously for 1 minute. Then you can give 0.05 to zero point 0.1 mg per kg per minute for about 4 minutes. Okay, and apart from that, you have atenolol and metoprolol. So atenolol among beta blockers is one of the commonly prescribed drug. Okay, mainly for the treatment of hypertension. It's one of the selective beta 1 blocker, and it is having very low lipid solubility. So now because of that, it does not produce any other the severe side effects. And the initial dose of atenolol can be can be started from 50 milligrams per day, once in a day, that is OD, to up to several weeks you can give. And later, depending on the requirement, you can increase the dose up to 100 milligrams. The common route of excretion of atenolol is through urine, and half-life of atenolol will be there up to 8 hours. Another drug, that is metoprolol, that is also a cardioselective beta 1 blocker. So the main advantage of being cardioselective is metoprolol can be used safely in patients who are having diabetes. Okay, and the initial dose of metoprolol can be started by 100 mg per day, and you can increase again depending on the requirement, or until there will be you see a proper reduction in blood pressure. Another drug, that is labetalol. This is first adrenergic antagonist, which is having action towards both alpha and beta receptor, which is a partial agonist of beta 2 receptor, in the sense it is having intrinsic activity towards beta 2 receptor. Now, because of this intrinsic activity, labetalol tend to produce or tend to cause vasodilation and bronchodilation. So the common uses of labetalol is mainly in the chronic hypertension, or it can be given in hypertensive emergencies, pheochromocytoma, or even in clonidine withdrawal, or pregnancy-induced hypertension. Common side effects which can be produced by labetalol is mainly postural hypertension, that is mainly because of the vasodilatation and also a failure of ejaculation or sexual dysfunction. So beta blockers, as we used to mention repeatedly before, they are mainly used, they also can be used in the treatment of congestive heart failure. But in congestive heart failure, they do not become the first line drug, but they prolong the survival rate of the patient who have got heart failure or they undergone congestive cardiac failure. So usually they can be given in cases of dilated cardiomyopathy, especially if they are associated with a systolic dysfunction. Okay, and in case patient is getting acute cardiac failure, then you should not try to give these beta blockers. Okay, so whenever if you're going to start as a adjuvant therapy in case of congestive heart failure, you have to start beta blocker from a very low dose, and as per the requirement, you have to titrate the dose upward as and when required. Another drug, carvedilol, so which is a alpha 1, beta 1, and beta 2 blocker. Along with the blocking these alpha and beta receptors, it also got additional antioxidant and anti-inflammatory property. So the antioxidant property is mainly because it inhibits free radical associated lipid peroxidation and mitogenesis, especially in the vascular smooth muscles, and reactive oxygen species mediated stress induced hypertrophy, cardiac hypertrophy. So because of these reasons, it can be used as a cardioprotective agent, especially in a patient with the congestive cardiac failure, hypertension, and left ventricular failure following myocardial infarction. In angina, again, these beta blockers are very much beneficial. That is why because beta blockers tend to reduce the cardiac workload, right? So beta blockers, they block the beta receptor, right? So by blocking beta receptor, they tend to reduce the heart rate, they tend to reduce the cardiac work. Whenever there is a cardiac work is reduced, the oxygen consumed by the heart tissue or cardiac tissues also will be reduced. So in turn, this totally reduces the cardiac workload. And along with that, they also improve the exercise tolerance or exercise capacity. But one thing you need to remember is you should not stop beta blockers abruptly. That is mainly because if you stop the beta blockers abruptly, then there is a high chance that it can precipitate angina or myocardial infarction. That's mainly because it will lead to abrupt stoppage or abrupt withdrawal, can lead to the upregulation of beta receptor. So once there is upregulation of beta receptor, so these beta receptors are exposed for the binding of agonists, for example, say adrenaline or noradrenaline. So that will lead to the precipitation of angina or myocardial infarction. And they are absolutely contraindicated in case of Prince metal angina or vasospastic angina. That is mainly because in these cases, vasospastic angina, this is mainly because of the unopposed, that is mainly because of the alpha receptors. Okay. So when you block the beta receptor, there'll be availability of the alpha receptor. So there'll be a unopposed alpha mediated vasoconstriction, right? So that will aggravate the condition. So that is why you should not use beta blockers in cases of Prince metal angina or vasospastic angina. Beta blockers also employed in case of myocardial infarction. So the main advantage of beta blockers in myocardial infarction is mainly because they limit the infarct size. That is mainly because they tend to reduce the oxygen consumption by the cardiac tissue. So now because of that, it can prevent the reinfarction, and also they can prevent cardiac arrhythmia. That is mainly by acting on the SA node and AP node. Okay, and you need to keep in mind that you should not be give these beta blockers, especially if the heart rate is less than 60 beats per minute, and systolic blood pressure is less than 90 mm of mercury, and the PR interval is more than 0.24 seconds. And whenever there's a myocardial infarction, within 4 to 6 hours, you can start giving metoprolol, that is around 5 mg intravenously for every 5 minutes, can go up to 3 doses. And you can also try with the oral dose, that is 25 to 50 mg oral dose every 6 hours only. It can also be used as a prophylactic agent. So what it does, the main benefit of beta blockers is they reduces the mortality rate by 20%. So that is mainly by preventing the reinfarction and also by preventing the sudden ventricular fibrillation. So whenever there is a second attack of myocardial infarction. So apart from that, these beta blockers can be used in the treatment of cardiac arrhythmia. So they are mainly useful in supraventricular and ventricular arrhythmias. And why they are useful? Mainly because they reduce the automaticity, especially in the sinoatrial node and also in the Purkinje fibers. And they increases the AV nodal refractive period. They reduces the ventricular ectopic activity, that is extrasystole, that can be reduced. So because of those beneficial effects, beta blockers can be employed in the treatment of cardiac arrhythmias. So there are two drugs, that is esmolol and sotalol. So esmolol, it's mainly used for the treatment or to terminate paroxysmal supraventricular tachycardia, or it can be used in the treatment of pheochromocytoma. But when you're using these beta blockers in pheochromocytoma, you need to know that without using alpha blockers, you should not try beta blockers. And it can be used also in the intra or post-operative hypertension. So another drug, that is sotalol. So the main benefit of sotalol is having its additional potassium channel blocking property. And because of that reason, it is also used as a class 3 antiarrhythmic drug. So it's mainly used in treatment of ventricular tachycardia and fibrillations. So apart from these cardiac uses, they also can be used in dissecting aortic aneurysm and hypertrophic obstructive cardiomyopathy. So this hypertrophic obstructive cardiomyopathy, that is mainly, which is subaortic. And in this condition, what happens is there will be a forceful contraction of your cardiac tissues, especially whenever patients, they do continuous exercise or whenever they undergo too much of emotional stress. So during these cases, what happens there will be an increase in the cardiac heart rate, cardiac work, everything will be increased. So this can be decreased by giving beta blockers. So the non-cardiac uses of beta blockers mainly includes in the treatment of migraine, anxiety, or essential tremors. Essential tremors, as I said, like in case of long-term usage of adrenergic agonists in case of bronchial asthma. And again, it can be used in alcohol or opioid dependence or akathisia. It can be used in pheochromocytoma. That is because pheochromocytoma is a tumor in the adrenergic gland, adrenergic gland, right? So, but you need to remember again, you should not use beta blockers without giving alpha blockers. Okay, and it can also be used in the treatment of glaucoma. Among beta blockers, timolol and betoxolol are very useful in the treatment of glaucoma. That is in the form of topical application. They can be used in hyperthyroidism. That is mainly propranolol. The propranolol, why it is used? Mainly because propranolol can prevent the peripheral conversion of T4 to T3. So because of this reason, it can be used along with the carbimazole or radioisotope of iodine or acid iodides, or it can also be used in case of emergency, that is a thyroid storm. In these cases, or along with the other drugs, they can be used in cases of hyperthyroidism. And again, glaucoma, as I mentioned previously several times, it can be used for the treatment and also management of glaucoma. It got several benefits. because it does not cause any changes in the pupil size or does not produce myopia. Usually, whenever you use myotics for the treatment of glaucoma, what happens is patients tend to get very severe headache, and there'll be fluctuations in the intraocular tension or intraocular pressure. And another advantage of giving topical beta blockers is it is very convenient for the patient, as and when they require, they can apply that by themselves. So even though beta blockers have these many beneficial effects or benefits or clinical uses, they tend to have several or various side effects. One of the common side effects which is produced by beta blockers is heart block itself, because especially if you're using this beta blockers, especially in patients who are having myocardial insufficiency, or in that cases, it can precipitate congestive cardiac failure, or it can cause heart block. And another thing is, because of the beta blockade, it can cause cold extremities. That is mainly because there will be unopposed alpha receptor activity. So that will lead to cold extremities. And uh, after the patient, once patient gets myocardial infarction, and after that there's a high chance that patient will be having a hypertensive state. Okay. And in case of pheochromocytoma, if you're using beta blockers alone, then there is a high chance that it can precipitate hypertension in the patients. And the whenever there will be a renal insufficiency or hepatic insufficiency, then metabolism of the beta blockers will be reduced, and that will lead to the increased bioavailability. So at some cases, the increase in the bioavailability is a benefit, but in some cases that can lead to the increase in the pharmacodynamic activity of beta blockers. So that beneficial effect lead to adverse effect. And they can cause bronchoconstriction in case if the patient is having hypertension and bronchial asthma, and you give non-selective beta blockers, then they tend to cause bronchoconstriction. That is mainly because of the beta blockade of beta 2 receptor. And they tend to cause hypoglycemia. They will mask the signs and symptoms of hypoglycemia, and also they cause alteration in your lipid profile. They cause changes in increase in LDL HDL ratio. So if the drugs are highly lipid soluble, then they can cause fatigue, or they can produce sedation, insomnia, depression, or nightmares. Okay. So, and in cases of overdose or toxicity which are produced by these beta blockers, then what you can do is you can give atropine to those patients. Atropine is an anticholinergic drug. Why you have to give is atropine, it acts as a cardiac pacing agent. And that is the one thing. And another thing is glucagon. For example, like beta blockers, if they produce hypoglycemia to a severe extent, then you can give glucagon. Glucagon tend to increase your blood sugar level by releasing glucose from the liver. And abrupt withdrawal of these beta blockers can tend to precipitate hypertension, or it can produce rebound hypertension, or it can precipitate angina or myocardial infarction. So that is why you should not stop beta blockers abruptly or all of a sudden. There are a few newer beta blockers, for example, say nipradilol or dilavalol. Okay, so these are mainly non-selective beta blockers, and they have selective activity towards alpha blocking property. So because of that reason, mainly nipradilol is mainly useful in the treatment of glaucoma, and dilavalol is mainly used in the treatment of hypertension. So to summarize, uh, beta blockers, you have mainly three beta receptor, right? Beta 1, beta 2, beta 3. So you need to know their location and function. So if you know what are the in which locations your beta receptors are present, beta 1, what is the location, beta 2, what is the location, and beta 3. And if you know when and what happens when an agonist binds to these receptors and what actions produce, then it will be easy to remember all the pharmacological actions which are produced by the beta blockers. Because if you remember one chapter, that is the adrenergic agonist, that is a beta agonist, then all the effects which are produced by beta agonists are blocked by beta blockers. So commonly, these beta blockers are useful in the treatment of heart failure, hypertension, and also it can be given in emergency. Uh, then, other than cardiac uses, it can also be useful in migraine, the treatment of migraine, and as a topical application, timolol also can be useful in the management of glaucoma. Thank you. I hope I could able to slow down.
Hi, yes, class was good, and it was, yes, it was really good.
Yeah,
And
because I didn't know how.
speed was even maintained at the end. I mean, since starting only few, slides were gone in quite
Yeah,
fast,
yeah,
but
yeah,
later on you maintained nicely.
yeah. Thank you, thank you.
So one of our, student is asking how long patients can stay on beta blockers.
A patient, depending. See, whenever you're giving a beta blocker for a patient who is on hypertension, then usually you say whenever a patient gets a hypertension, it's a lifetime disease, right?
Yeah,
So you need to see, you need to know, you need to concentrate mainly about what dose you're giving and what are the side effects which are produced by the drug in that particular dose. If there is no notable or severe side effects which are produced, then you can put the patient as long as you want.
yeah, exactly. So it's not necessary. It's not like the patients have to take only for 2 months or 3 months or 4 months.
Yeah,
They can
correct,
take for even long term also if they are
correct,
not showing, they're not reducing their heart rate or they're not,
correct.
getting any other side effects.
Yes,
Yeah, so they can continue for long term as well.
correct. Yes.
Yeah. Okay, and that's great. Thank you, Priyanka. And I will just see in the YouTube if we have any comments there. Okay.
Okay.
Sir, you said esmolol is used in emergency. Then how can we give alpha blockers first and which one is to be given?
See, that is, I said alpha blocker, that is mainly pheochromocytoma. See, in pheochromocytoma, what happens is whenever, especially during pheochroma surgery, the stored adrenergic, for example, say adrenaline or noradrenaline, that will get released, right? So
Yeah,
whenever they are released in a large amount, what happens? They stimulate both your alpha and beta receptor because they are agonist towards beta and alpha receptor. So
true,
at that time, if you give only beta blockers, what happens? The alpha receptor are exposed open. So
true.
these adrenergic agonists, catecholamines, they can directly act on alpha receptor and they can produce agonistic effects, which are produced by the stimulation of alpha receptor. So that is why to prevent that, you have to give both alpha and beta blockers together whenever you are going to do a surgery, especially on a pheochromocytoma patient.
Correct. True. Exactly. So
Yeah.
now our next question here is, what is the most commonly used cardio selective beta blocker? See, by the way, see,
Yeah.
cardio selective cases. Yes, yes, Dr. Kiran.
Yeah, see, very commonly here in our hospitals, commonly they prescribe atenolol or metoprolol, right?
Yeah.
So it is not, these two are the very commonly prescribed one, but other than that, you can say whichever, which
See, by the
you,
way, I'll add on to your
yeah,
answer, Dr.
correct,
Kiran. See, heart failure, we usually, go for carvedilol, and then because carvedilol is newer drug and
correct,
have the great efficacy along with carvedilol, now bisoprolol. Okay,
yes,
bisoprolol
correct,
has a great effect on heart failure, guys. Okay, so in heart failure cases, we go for carvedilol and bisoprolol, and in MI cases, metoprolol is preferable.
yes.
Yes, as Dr. Kiran said. Yes. So any other question, guys, for Dr. Kiran? No, I don't think so. So then we'll wind up. Dr. Kiran, thank you very much for joining us, and it was a wonderful session. Our students, are privileged to have you on board here today for the class, and it was really a wonderful class. Thank you very much for joining, and yeah, give your insights to our students. Thank you very much.
Thank you. Thank you for the
Yes,
opportunity.
yes.
Thank you.
Good. Yes. Good night, everyone. Take care. Bye bye.
Yeah, good night.